First of all, I would like to thank all the panelists, all the speakers tonight, and I would like to welcome all our attendees from all over the world. Another fruitful night, wonderful night of the MEGA online course. Tonight we have extraordinary speakers. We have two wonderful lectures, and I'm sure that all of you will enjoy it. To start with, we have Professor Khalid Abdelhamid, Professor of Anesthesia and Pain Management in the National Cancer Institute in Cairo University. Professor Khalid is the current president of the Egyptian Society of Chronic Pain Physicians. He's the former head of Anesthesia and Pain Department at the National Cancer Institute in Cairo, and he's the founder of the Egyptian Society of Chronic Pain Physicians, which was founded in 2016. The society is very active. Since its establishment, it delivered 12 workshops and an international conference, which encouraged a new promising generation of physicians in the field of pain medicine. Tonight, Dr. Khalid will talk to us about the transition from acute to chronic postoperative pain. So with no further ado, I would like to welcome Dr. Khalid and give him the microphone.
Thank you very much. Bismillah ar-Rahman ar-Rahim. Hi, everyone. At first, I am so glad to join and be one of the presenters of MEGA online course. I am so grateful to Professor Saad Mahdi for choosing me, and really I am proud of his work and devotion and wishing him very good luck. Today, I will explain the role of anesthesiologist to help in prevention of transition of acute postoperative pain to a chronic one, which is so difficult to treat, as I will explain. Also, I will declare and discuss the importance of the concepts of multimodal and preventive analgesia and how to apply. During my presentation, I will put some questionnaires to clarify my messages and make them delivered easily. At first, I will summarize the drawbacks of inadequate postoperative analgesia. As we all know, the recumbent patient, because of pain, has high tendency to develop deep venous thrombosis, high tendency to develop pulmonary complications. He has delayed healing process, and also in oncological surgery, the metastatic lesions may be more than a patient with adequate analgesia, because inadequate analgesia lead to decreased immunity of the patients, and the malignant cell can settle in other sites and the patient develop metastasis easily. As I work in National Cancer Institute, I saw this many times. So we learn our fellows that laparoscopic oncological surgery equals epidural, catheter, and adequate analgesia. The most worst of them is the development of chronic post-surgical pain syndrome or situation. My first questionnaire, chronic pain is a continuous acute pain. Is it true or false? Really, it is a very false concept. Before we discuss it, we must define what's acute pain and what's chronic pain. Acute pain characterized by recent onset, predictable, more or less predictable duration, which is the duration of the healing process of the injury, and the cause is very clear to the physician. But chronic pain commonly persists beyond the time of healing. It has no cause. Obviously, you may see it is no cause. Why the patient is in pain? The operation is very good. The plates and the screw are in place. Why they are in pain? So it is important to differentiate between acute and chronic pain. Chronic pain commonly persists. These are beyond the time of healing and the injury, and frequently you may not find any cause. The International Association of Study of Pain define the chronic post-surgical pain as pain developed after a surgical procedure of at least 2 months duration, and the other causes have been excluded, like continuing malignancy or infection, and this must be excluded by proper workup. So if it fulfills this criteria, this is a case of chronic post-surgical pain. Why it is happening? Chronic post-surgical pain happens because there are many changes in the CNS, which is called the neural plasticity, which developed a new state of pain perception in the CNS, especially in the spinal cord lamina 2, which is the site of the relay between first order pain neuron and second order pain neuron. This neuroplasticity may be in form of increased receptive field, may be in form of activation of lambda receptors, may be in form of more production of stimulatory neurotransmitters. This will lead to a new state of the CNS. The CNS becomes sensitized, becomes always sending signals to the cortex that there is pain in that place or in another place, as I will explain. This slide is very important. If we start by surgery or injury, it is acute pain due to activation of the nociceptive fibers. But if this activation sustained for a time, it will sensitize nociceptor fibers. It becomes more sensitive than usual, becomes more sensitive than the intensity of the injury. And the patient complain of hyperalgesia. This state is a prolonged subacute pain. With continuity of this nociceptive impulses, the CNS will go into a new state of central sensitization or CNS neuroplasticity with structural remodeling, as I said, increased receptive field, activation of lambda receptors, and so on. And this is a chronic pain state, which is very difficult to treat if we reach this situation. It needs aggressive treatment. It needs multimodal treatment. So the chronic pain syndrome, especially postoperative chronic pain syndrome, must be treated by multimodal and multidisciplinary mode, pharmacological, non-pharmacological, interventional, and psychological social. If we don't apply these modalities, you will not cure the patient with chronic post-surgical pain syndrome. It is so difficult. So it is very important for anesthesiologists to be aware of this and to try to treat acute postoperative pain adequately at all times in the early and late postoperative period to help in prevention of this catastrophic syndrome. The second questionnaire, as all anesthesiologists, that the patient did surgery, so mild acute postoperative pain is acceptable. No, it is not allowed. Why it is not allowed? Because of this slide you saw before. So this slide explains what I mean. No, any acute postoperative pain is allowed for prolonged time. Try at any time, on all times, to ameliorate this pain and to prevent the development of chronic pain. The third questionnaire, chronic postoperative pain is not a common problem. Is it true or false? It is a common problem. As we see as pain physicians, we face every day many cases of chronic postoperative pain syndrome. In this study done 30 years ago in 10 UK hospital-based pain clinics, that 22.5% of cases attending this pain clinic have or had chronic post-surgery pain. It's a big percentage. It's 30 years ago. I think surgery at that time was not extensive like now. And now there is more extensive surgeries and more extensive trauma to the patient. In another Turkish study, in 2009, they determined the incidence of chronic pain in certain operations. Post-mastectomy, 20 to 50%, thoracotomy, hernia repair, amputation, cesarean section, hysterectomy, hip arthroplasty, coronary artery bypass graft, vasectomy, cholecystectomy, colectomy. And I increase the post-laminectomy syndrome, which we see every day, hundreds of cases every month after back surgeries and fixation and so on. Post-laminectomy syndrome is the most common, I think it is the most common chronic post-surgical pain syndrome. But this slide shows that we have a good percentage of chronic post-surgical pain in certain operations. The next questionnaire is chronic post-operative pain is almost always a responsibility of the surgeon. The surgeon is not well trained. He injures some tissues, he injures some nerves. He didn't know his way. This is maybe true, but he is not the only one responsible. The type of patient, the role of anesthesiologist, and the type of operation, and the cleverness of the surgeon, and the awareness of the surgeon about this syndrome, these all factors share in production of chronic post-surgical pain syndrome, and awareness and the knowledge of these factors will decrease the incidence of chronic post-surgical pain syndrome. This sum of the putative risk factors for chronic post-surgical pain is very important. The pre-operative factor, like psychological factor. Yes, the patient in depression or anxiety or schizophrenia is more vulnerable to have sustained acute post-operative pain and development of chronic post-surgical pain syndrome. Also, the pre-existing pain syndrome like fibromyalgia, headache, low back pain, irritable bowel syndrome, all these patients have centrally sensitization already. So they are very vulnerable to develop chronic post-surgical pain syndrome. The preoperative pain in the surgical site may share, and as we all know, the patients which will be subjected to amputation if they intubated before or the skin incision before proper analgesia, the patient very high risk of developing phantom pain and stump pain. It's very important, and many researches prove that fact. Also, the younger age group, the younger the patient, the more risk of developing post-surgical pain. Genetic and environmental components, because of every patient, every man, every human being has certain number of opioid receptors. If this opioid receptor number is low, he is very sensitive to pain and very subjective to chronic post-surgical pain syndrome, and vice versa. So the genetic and the environmental components is very important. Intraoperative factors like nerve handling and the injury, it is the surgeon's fault. Okay. Type of incision, it is the operation fault. Is it laminectomy? Is it inguinal hernia repair? Is it thoracotomy? Is it sternotomy? Is it mastectomy? The type of incision can increase the incidence of that syndrome. Non-utilizing nerve-sparing techniques. The surgeon is not aware about, especially oncological surgeon. They do not respect the tissue, including the nerves. Type of surgery, as I said, the location, some operations have higher incidence. Use of mesh in inguinal hernia, staples, external wire. The most important, and it is the anesthesiology fault, is inadequate management of acute post-operative pain, which our main job. As I discussed with Dr. Saad before the presentation, our job as an anesthesiologist is not to intubate the patient and make him sleep during surgery and then go away. He is not my patient. No. It is improving the outcome of surgery. The goal is that the patient will be cured from his original disease and go home with no complication. So it is very important to adequately control acute postoperative pain. Maybe disease recurrence at surgical site because of pain and ignorance of treating such pain may lead to chronic post-surgical pain syndrome. And lastly, the use of chemotherapy or radiotherapy as the site of the operation will increase the damage and will lead to chronic post-surgical pain syndrome. And I saw this very frequently, especially with radiotherapy after thoracotomy for mesothelioma or bronchogenic carcinoma and so on. The patient is complaining of intercostal neuralgia because of radiotherapy after surgery. So beware about these all conditions. You have to put a strategy for every patient. For a patient doing mastectomy, for a patient doing thoracotomy, for a patient doing inguinal hernia repair. Every case is a distinct case. You must manage separately according to the understanding of the risks of developing such chronic pain syndrome. The next questionnaire is chronic postoperative pain is seen only in operations involving and or injuring part of peripheral and or central nervous system. Is it all neuropathic pain? No. This is not true. It may be due to somatic pain, soft tissue pain, bone pain. This is somatic. Psychological aspects must be respected. Myofascial pain syndromes in patients susceptible to that, like fibromyalgia and chronic fatigue syndrome, myofascial pain syndrome may develop pain after surgery. And it is a unique type of pain. It is very important. And lastly, the neuropathic pain due to either direct injury or another causes like phantom pain or sympathetically maintained pain like complex regional pain syndrome, which I mean reflex sympathetic dystrophy and causalgia. Somatic pain may be due to remaining primary pathology, like vascular disease, tissue damage from trauma, additional stress on affected and not affected joints and tissue, like due to altered biomechanics and overuse syndrome of remaining structures and tissue. So somatic pain is very important as a source of chronic post-surgical pain and the development of chronic post-surgical pain syndrome. You must search for. This slide is very important. It is the complex regional pain syndrome. It is a very common situation, not common, it is rare, but you have to, it is not uncommon, it's not rare, it is not uncommon, but you have to be aware of this. This patient, for example, do carpal tunnel syndrome. Is it normal after carpal tunnel syndrome, say 6 months after this operation, the limb become like that? No. It is swollen, it's painful, it is hot, it is red. This type of disability makes the surgeon thinking of deep venous thrombosis, no, this cellulitis, and so on, and they ignore the development of complex regional pain syndrome. So the anesthesiologist must be aware of this syndrome. And it is very important in such operation like carpal tunnel or arthroscopy knee, which may accompanied by nerve injury, to do adequate postoperative analgesia to decrease the incidence of developing such a lethal syndrome. Although there is a genetic predisposition to such syndrome, and you can take from the patient history, if you can, if the patient can inform you about that, especially in limb surgeries, it's very important. The next questionnaire, opioid alone can treat acute postoperative pain effectively. This is absolutely false. And the concept of multimodal analgesia, was developed to decrease the need of opioids or to be opioid-free analgesia post-operative because of side effects of opioids like tolerance, like induced hyperalgesia, like nausea and vomiting, and so on. The concept of multimodal analgesia simply you have to deal with the pain pathway at all steps by specific measures and the pharmacological agents to use small amounts of every drug and to avoid the side effect and to use minimal doses of opioids. So at the site of injury, opioids doesn't work. So you can do local anesthetic block. You have to use anti-inflammatory agents, COX-2 inhibitors. It's very important. Because if you have to treat pain, you must treat the origin of pain and the pathway of pain. What is the methods of treating pain at the origin? It is the local blocks and the anti-inflammatory drugs. If you can't do local blocks, you have to give non-steroidal anti-inflammatory drugs unless it is contraindicated. Then the first order neuron, the nerve, can be blocked by local anesthetic. So this is peripheral nerve block. Then in the spinal cord, lamina 2, the first order neuron will transmit pain signals to the second order neuron. This area of spinal cord, you can do spinal, you can do epidural, both epidural catheter by local anesthetics, opioids, alpha-2 agonists, and lambda antagonists like ketamine, alpha-2 agonists like clonidine, opioids like fentanyl, or preservative-free morphine, local anesthetic. So the epidural catheter is very important in prevention of or amelioration of acute postoperative pain and must be used in cases selected. Then this is the pathway. It will cross to the opposite side in the spinothalamic tract and go to the brain. In the brain, what is work? Opioids can work in the brain. Alpha-2 agonists can work. Centrally acting analgesics, acetaminophen. You have to give acetaminophen, paracetamol, anti-inflammatory agents. So all these agents can be work on the cerebral cortex. So multimodal analgesia must be applied for every case of acute postoperative pain to minimize the use of opioids. And you have to do local blocks and central interruption of pain signals by your sense of as an anesthesiologist. Which opioid? Can we give fentanyl? Yes. Can we give morphine? Yes. Oxycodone? Yes. Mipridine is contraindicated. Now, in Egypt, we see all the anesthesiologists give mipridine, which is betadine in Egypt. This is a very bad opioid. It is asynthetic. It is very short acting. So you have to give it every 2 hours. High incidence of nausea and vomiting, high incidence of addiction, and the most worst is the degradation product of it, which is normipridine, which is neurotoxic and accumulated with repeated injection of bethadine, and the patient may develop CNS toxicity in the form of convulsions. So please don't use mipridine or betadine literally. Use fentanyl, use morphine, oxycodone, now registered in Egypt and Bul. The next, pre-emptive analgesia is enough to deal with postoperative pain. It is a false idea and old idea that the analgesic dose of fentanyl or morphine just before intubation and before the skin incision is very helpful, and it is only satisfactory for prevention of postoperative pain. which is false. Now we have the concept of preventive analgesia. What is this concept? Preventive analgesia, including preemptive and other. Preventive is a strategy. Preventive must be preoperative, must be intraoperative, must be early postoperative and late postoperative. The preoperative, 3 or 4 days or 1 week before, we can give oral medications like anticonvulsants, pregabalin and gabapentin, which help in decrease of axonal transmission of pain signals later on when we develop a plasma level satisfactory to do this before surgery, and preemptive, which is just before the skin incision, is also part of the preoperative. So the preoperative must be start 3 or 1 week before operation, and the preemptive at the time of skin incision. Then intraoperative analgesia is very important. Don't rely on one ampoule of fentanyl 100 microgram given at induction and it will be okay for all the time of the operation, 3 or 4 hours. No, you have to monitor the patient for signs of inadequate analgesia and deal with it. You can give non-steroidal anti-inflammatory, you can give more opioids, you can give ketamine infusion, you can give local anesthetic at the site, intraoperative if you can. So it is very important. Also, the early postoperative, the first 24 hours, and the late postoperative in the rehabilitation period, especially in joint replacement and orthopedic surgery. It is very important the patient has no pain and early ambulation to prevent the development of chronic postoperative or post-surgical pain syndrome. Here, there is a meta-analysis of the use of the anticonvulsants like pregabalin and gabapentin in prevention of the chronic post-surgical pain syndrome, and it shows that pregabalin is more effective. Why pregabalin is more effective than gabapentin? Because the pregabalin bioavailability is easier to develop than gabapentin. Gabapentin, most of the drug which is taken orally, or the two drugs are taken orally. No IV preparation till now. So the pregabalin, which is Lyrica, the high bioavailability of Lyrica make the plasma level to reach the steady state in a shorter duration than the gabapentin. So if we start pregabalin 3 days before the operation, be sure you have sustained a plasma or a steady plasma level, but gabapentin needs more time. So it is recommended to use pregabalin. Also, as I said, ketamine as NAMDA antagonist is very important, but till now, the meta-analysis does not support that it is significantly reduced post-operative pain at any time, but personally I use it and I found many advantages of using ketamine intraoperatively. Sure, you have to put the patient in patient-controlled analgesia, either electronic or disposable. The next questionnaire, we cannot anticipate and measure incidence of chronic post-operative pain. No, we have some trials of measuring and anticipating the incidence of chronic post-operative pain in some patients. Kalkman pain reduction, which is developed 2008, put some criteria: 6, female take 1 point, male 0, age younger, as I said, take more points, pain before surgery at the site, if it is present, take points, regular use of opioid 1 point, regular use of anxiolytic antidepressants 1 point, open surgery it's 1 point, type of surgery, thoracic, abdominal, orthopedic, okay, long-acting procedures, obesity, high level of anxiety as the pre-operative visit. All these factors I explained to you before. The risk intense post-operative pain is important when the score is 4 or more or 50. So you can apply this Kalkman pain prediction. It will give you a rough estimation about the possibility of developing chronic post-operative pain syndrome. The next questionnaire, chronic post-operative pain can be controlled by conventional treatment modalities, by some pharmacological treatment. This is not true, as I said. It needs multimodal, multidisciplinary. So the most important is anticipation, prevention, and diagnosis. You have to anticipate from the type of the patient, the type of operation, the type of surgeon, as I said. You have to anticipate and try to prevent, and if it happens, you have to diagnose and go to the oral medication, physiotherapy, exercise, rehabilitation, behavioral medicine. You can do corrective surgery if the cause is obvious. You have to do your job as an anesthesiologist, diagnostic nerve block, therapeutic nerve blocks, and then the major intervention like implantable pain management device, neurostimulation, intrathecal pumps, and neuroablation. This is the control. This must be done at the same time if it is indicated. If from the start we have to put this one, try the start. Okay, it is not like a step ladder, not a step ladder. The medication with physiotherapy, the intervention must be done at the same time. This slide shows you some medications which act on the peripheral sensitization, like local anesthetic, topical, anticonvulsant, tricyclic opioids, central sensitization, anticonvulsants, opioids, lambda receptors, and descending modulation of inhibition pain, like anticonvulsants, opioids, and tricyclic anticonvulsants. The next 3 slides, I will summarize some of the most common post-chronic surgical pain syndrome, like post-thoracotomy pain, and this is the research and the studies about this syndrome. The incidence is 30 to 50% due to surgical incision itself, rib retraction, intercostal nerve injury, evidence with operative evoked motor potentials, trocar placement, chest tube placement, suturing technique, pericostal nerve injury, and rib fracture. So the post-thoracotomy syndrome, pain syndrome, may be neuropathic and may be nociceptive, may be due to muscle itself, muscle injury itself, and they need Botox injection, for example, and the patient will be okay. Not every case needs intercostal nerve block and neuromodulation or neuroablation. The chronic post-surgery pain may be seen up to 50%. Post-mastectomy pain has 4 components. The patient may complain of phantom breast pain, like phantom post-amputation pain. Exactly. Intercostobrachial neuralgia, and it has a unique distribution and must be treated by sympathectomies and nerve blocks. Neuroma pain, the same treatment as intercostobrachial neuralgia and other nerve injury pain. This is the post-mastectomy pain, which is one of the famous post-surgical pain. After inguinal hernia is one of the most difficult cases in chronic post-surgical pain syndrome. But you have to notice the type of anesthesia has no effect, either spinal or general. There is no effect on persistent post-surgical pain. There are many factors. The type of surgery, it is laparoscopic versus open more. Nerve sectioning versus nerve identification. Some surgeons cut the nerve believing that if I cut the nerve, the syndrome will not happen. This is wrong because you injure the nerve. And the proximal end will send the impulses to the brain that there is pain, pain, pain. Recurrent hernias and use of and measure the dissection and the use of mesh will increase the incidence, and also the patients with pain, with higher pain sensitivity may develop this syndrome easily. And this is one of the most difficult cases I met. The take-home message, chronic pain syndrome following surgery are at least as difficult to treat as other neuropathic pain. Very important to prevent. than palliation. Multimodal analgesia technique should be used in every surgical case to provide maximal analgesia with minimal side effect, and this is most likely to reduce the chance of developing chronic post-surgical pain. What we need? We need to design better clinical study. Prospective, procedure-specific approach. We have to do study on post-thoracotomy pain syndrome. What are the causes and how to manage and how to prevent. To identification of all risk factors and include long-term follow-up. We need more awareness of chronic pain. Acute pain service team must be included in anesthetic process with regular education and training is very important, and thank you.
I would like to thank Professor Khalid for this lovely presentation.
Thank you.
Very fruitful, very thorough. We've got some questions. The first one is about nalbuphine and its use. So I think it's used as part of the management of acute pain.
About Berfalgan?
No, nalbuphine.
Nalbuphine. Yeah.
Nalbuphine.
Yes. Yes, I agree to use nalbuphine as an opioid in treating acute postoperative pain, provided that the patient is not opioid tolerant. It is not in agonist, in pure agonist. Is not like an oncologic patient on transdermal fentanyl patch or taking morphine tablets and then subjected to surgery. It is contraindicated to give him agonist antagonist like nalbuphine because he can develop withdrawal symptoms and lack of analgesia. So once nalbuphine is used, is only nalbuphine, no with other agonists.
So another question about ketamine and the dose of ketamine if used intraoperatively, and what's the ideal dose for the infusion?
Yes, we use sub-anesthetic dose about 0.5 to 1 milligram per kg by intravenous infusion over 1 hour.
And I may add to this, there's also some guidelines from the United States, yes. From the Society of Anaesthesiologists in the United States regarding ketamine. And I think these are the only guidelines present currently regarding the ketamine as a bolus and an infusion. There's also a question about chronic post-hernia repair pain.
Yeah.
What's the incidence and other interventional pain management for this type of pain?
The incidence about 30%, especially in recurrent cases and young patients, young age, from 30 to 40. I saw the most of cases at this age group. It's about 30 to 40%. It's very difficult to treat. My experience, as I said, I have to manage the origin of pain. So I examine the patient and examine the incision. Most of cases, I can feel neuroma along the incision. I can feel neuroma. If I feel this neuroma, I can inject corticosteroids around. This is the management of the origin of pain. Then we can do another blocks for the pathway of pain. We can do ilioinguinal or iliohypogastric or genitofemoral blocks or RF sonar guided. If the distribution of pain with some of these nerves. And lastly, we can do sympathetic lumbar sympathetic block. As you know, the sympathetic nervous system is always work as pain generator in neuropathic pain because of sympathetic sprouting in neuromas. These neuromas that the surgeon creates in the nerve supply of this area now is innervated by sympathetic. So we can do sympathetic nerve block like lumbar sympathetic block in inguinal hernia, and we can inject steroids around the neuroma if you feel it, and we can do radio frequency or block for the offending nerve.
Okay, we'll take two more questions. The first one is about the role of magnesium in multimodal anesthesia or
it has a
analgesia.
role, magnesium, because as I said, it is the lambda receptors will be open and working, and these lambda receptors share very much in the release of excitatory neurotransmitters. Why is lambda receptors is open? Because the magnesium plug closing these receptors will be will be expelled from these receptors, and so the receptors will be open. In giving magnesium, it will replenish these magnesium plugs and help too much in prevention of such pain.
And something also about the use of oral alpha-2 agonists in the preoperative period. So I think what the question means is that using alpha-2 agonists for some time before the surgery, not intraoperatively or just as a preemptive just before the skin incision.
Unfortunately, now in Egypt, we have no clonidine. Since 30 years or 20 years, clonidine was present in Egypt. Now it is not present. We can use it in the preoperative period. It is an antihypertensive drug. We can use it in the preoperative period as part of preventive analgesia. In Egypt, we have catapress, but we have no vials of clonidine to be put in intrathecal or epidural pathway.
If I may answer that from basically from experience, the problem with the clonidine that I've seen is hypertension, which is very exaggerated in elderly patients, and also lost in the recovery period, which can last for some time. And we always have this problem, like patients cannot go back to the ward, or the recovery nurses doesn't want to send them back to the ward because of the blood pressure is low. And there's some evidence that actually low blood pressure affects elderly patients more than others, and can cause an increase in mortality and morbidity. So I'll be very cautious regarding the use of clonidine. I think we'll stop the questions at this point. Thank you very much, Professor Khalid, for this lovely presentation and lecture.